taking our clients to comprehensive services that can be available in our CTCs, but also reducing the unnecessary burden at the facilities, because we know we have stable clients who can receive their services in fewer visits at the clinics. So summarizing that, in the comprehensive client-centered approaches, we as Afya Yangu Southern Zone, we are using 4 approaches that we will be discussing today, which is going in line with the theme of Tanzania Health Summit 9th, to know that we need quality services. So the first approach is focused HIV testing through community index testing. And for this, we have been implementing different approaches from testing, index testing, which is focused. But we all know that WHO recommends 95% of identified PLHIV being linked into ART services. And UNAIDS estimates that 75% of people living with HIV are accessing comprehensive care. And in Tanzania, we're at 90%, and we have to stretch to get to 95%. So client-centered approach in 395s should be realized by 2030. So we all know that if we retain our PLHIV on treatment, we will reduce their clinical visits, and more so, they will continue to contribute in country's economy, but when they are suppressed, we are going to realize HIV-free generation. So the first approach, which I've said, is focused testing. We know that we need to reduce testing rates. We don't test everybody. We go to the pockets where there's a possibility of getting the HIV positive clients. For us, we wanted to showcase the services that we are offering to the PMTCT positive mothers by offering contractual and provide referral methods for index testing of their partners. So in this modality, we reach these clients at the community. When we elicit the HIV, the pregnant woman who is positive, we elicit the sexual partner using our trained personnel who have been training, and we can make sure that the client are being assessing the service at their community. And for this case, we focus on discordant couples. We all know that the prevalence of discordant couple is up to 40%. So those HIV negative identified partner, we offer them with pre-exposure prophylaxis services. And also we focus on demand creation and training to healthcare workers, community-based CHWs, including our peers. And we offer KVP peer support and monthly tracking of new hotspots in the areas that we support. But we want to monitor our performance, and we do it daily through our institutionalized COBO tool, which we monitor those HIV negative who have been initiated in pre-exposure prophylaxis services. So you can see that the contractual index partner notification for us, it has risen to our achievement, as you will see in the next slide. You can see also in this photo, this is Mr. XY, who has been benefiting from PrEP services, and the mother has used our PMTCT services from the supported facilities, and they have got a HIV negative child. So we are realizing the HIV-free generation if these strategies, which are institutionalized in the government SOPs, are being strengthened to support, to make sure that they are happening at the facilities. And tying that with the results, you can see this slide is showing our quarterly trends of year 1 of PrEP new versus target that we have been given. And you can see that in Q1, we are only at 2% PrEP initiation as Afya Yangu Southern Zone. but there have been progressive increment until we finish Q4. This is data up to 15th September. We have surpassed our target. Almost 6,000 clients who are HIV negative are receiving pre-exposure prophylaxis services in supported sites. So we are getting there. That we know that we offer services to those who are negative, but also those who are positive are initiated immediately to HIV testing. But also, we can see there's good progress across the regions. In the left bar graph that you can see, all the regions have been increasing tremendously by using this approach. Another approach that we are doing of our comprehensive services, client-centered, is adolescent teen club and Saturday clinics, where our activities, we offer adolescent care to these youngsters, the children and adolescent. We know that the adolescent and children does not only need a pill, they need psychosocial support and medical treatment, but also they have to be empowered on their self-esteem. And we are using a well-structured SOPs to make sure that these clients are accessing the care that they need. So the pictures are showing from our 60 teen clubs, where we have over 1,734 beneficiaries, and we are conducting Saturday clinics, where we have about 8,000 adolescents who are benefiting from this, from our 10,000 adolescents in care. We wanted to showcase the good progress that these initiatives are happening, and we selected high volume sites in Iringa, which is one of the most prevalent regions, and you can see that there's been progressive improvement, the suppression of adolescents. We know that many programs are struggling with suppression below 85%, but in Iringa, due to offering Saturday clinic and teen clubs, we are at 94% as we closed Q4 result. This is preliminary result, but you can also appreciate that they've been increasing progressive suppression to these adolescents. And another model of a comprehensive client-centered approach is integrated facility-led community RT services. And you can see this photo that the women are gathered, men and women are gathered at a small local health facility in hard-to-reach areas in Njombe. So you can see that integration of facility-led community RT outreach. We offer SECAP screening, that is cervical cancer screening, COVID-19 vaccination, but also HVL sample collection. So in this strategy, we have small groups also, but this one we are showcasing here is just a small non-supported health facility with only PMTCT services. But these women are gathered there to make sure that they get their ART. So what we do prior to that visit, we make sure we identify all eligible stable clients who can access that service from the CTC which were registered, but also we schedule these appointments so that we can reach them on their appointment dates. But also the program and sometimes CHMT are supporting the vehicle, and we make sure that we make a phone call reminders to the clients so that they come and we give them the drugs as needed. So in this, what we do, we also integrate the multi-month scripting. We give 3 for those eligible for 3 months drugs and 6 for those eligible for 6 months. So in this, you can see that the result in Q1, it was so low on the, let me use my pointer so that we can go together. So I was saying that this is a prescription of 6-month ART. So you can see integrating the facility-led community ART, we integrate also to give this client a high 6-month prescription. So you can see there's increment of provision of 6 months. We started at 26%, and up to Q4 we're at 54%. And there's decrease of 3 MMD because we know if a client have successfully used the 2 months, 3 months ART prescription can go to receive to a 6-month ART prescription. So there's decrease of 3 MMD, but there's increase. So in totality, you can see as a program, we are offering our clients up to 80% multi-month prescription. And the stagnant nature of this line, that is less than 1 month, you can see this is due to, it has to be like that because we have some of the clients who are unstable, they are newly identified. So in summary, we can see that the program aims at decongesting the clinic so that we can have more time to offer services to those who are highly in need. And in this integration also we do set up hub-spoke model, which is single visit approach. As Afya Yangu Southern Zone, we only have 21% of static sites offering single visit approach. And what is single visit approach? We make sure that when we screen these women at the same center of screening, we are able to treat them using cryotherapy and thermocoagulation machine for those with early signs of cervical cancer. So we know a single visit approach need skilled staff to screen, and at that time also they have to offer the treatment by using cryotherapy machine and VIA. So using cryotherapy machine, which the program is supplied, but we only have 140 sites, and we are in continuation, we support 676 health centers, CTCs. So this whole hub-spoke model helps us to offer comprehensive care to these women who are in reproductive age. And this reduce and prevent the cervical cancer and timely treatment, and aversing clients who could rather have a burden of cervical cancer. But now we have prevented up to 90% our treatment rates in the program. In this year, we almost have 300 women who are suspect of cervical cancer. But with this single approach spoke model, we've been able to averse this burden. So also we appreciate that this model, the cornerstone of its success, it's the engagement of RSHMT, but also DRSH core and RRSH cores. But we need to map. We were mapping the hard to reach areas with clients who otherwise they could not get this chance of being screened timely. So we identified also the mentors who are trained by Ministry of Health, SECAP department, because this screening is competence-based. So we are using the few mentors that have been trained and able to offer this screening to these hard-to-reach areas. As you have known that in Southern Zone, we are also impacted with fewer healthcare providers who are offering these services. So the hub-spoke model has had the tremendous results that you are seeing in this slide. You can see that this is our overall data preliminary by 15th September. We started at 4% in Q1, and you can appreciate that we have jumped to 68% by using this model. And we have invested so much mortalities and burden of cervical cancer to these women by operating this model. So our lesson learned will continue to screen women using this modality, and the few health facility competent staff or mentors are going to also equip these nurses who are coming from facility with no training. So what is our lesson learned? Integrated PrEP initiation and index testing modality offers continued prevention in continuum of care, but also teen clubs and Saturday clinics, have you seen an example in Iringa, offers children psychosocial and medical intervention, but also multi-month scripting, you have seen our result in the regions. As a nation, we're at 60% of multi-month dispensing, but for Afya Southern Zone, we are almost now at 80% if you put together the 3 MMD and 6 MMD. So this success, we are seeing that when you're doing community RT to stable clients, you make sure that you also offer a 6 and 3 MMD multi-month, which is client-centered. But also we want to advocate that with resource constraint setting, shortage of providers is inevitable, so we have to engage strongly the RHMT and Nation so that they conduct these outreach services and ask partners to be able to support and monitor the good documentation. I would like you to get the experience of a small clip that we shows Saturday Clinic, how it's conducted in our supported sites. Thank you.
Thank you very much, Dr. Lema Msimbe, for giving us the biomedical part of Afya Southern Zone interventions. And I would like now to welcome another presenter who will give us highlights on the SBC interventions in the Southern Zone. And on this, we would like to hear on the issues of sustainability, but also on the role that Afya played in the development of different tools for communications in collaboration with the ministry. So, Mwanakulia, you're welcome.
Thank you, moderator. As okay, thank you, Dr. Chawote. My name is Godfrey Manakuria, and as Dr. Chawote introduced me, I'm the SBCC manager for the program. So, Dr. Rehema has spoken more of the service delivery part, and I appreciate the good job that our service delivery team is doing. But the question that I have is, what if these services were there and people weren't going? That's the question that we should ask ourselves. In the previous session by Pathfinder, we are talking about abortion and all that. But do people actually know that the laws are there to allow them to do so? Do people understand that these services do exist in these facilities? But what are the norms within the communities with regards to abortion? So these are just examples of, as my opening statement, to what actually SBCC or social behavior change can do so that we first we raise awareness of our services, but second, we continue to address the social norms that hinder the service uptake. But third, we continue with a dialogue, because you have a patient, a PLHV person who came for testing and they start ARTs. But how do we ensure that these people come regularly to their visits to ensure that they continue with their medications and all that? But thirdly is the question of provider behavior. We know there are a lot of issues, biases with providers. How do we address these issues to ensure that young people are accessing the service, which is their right? And lastly, the issue of sustainability. How are we ensuring that our program are sustainable? And this brings us to the question of client-centered approach, where we design with the client, we deliver together, and we evaluate together. So to me, I think that's some of the issue that Dr. Hema was talking, because we know we need to achieve the 95 and reach the epidemic control. But there are those things that are not biological, and the nurse cannot address them. The doctors, the physicians are not to address them. And this can only be addressed through social and behavior change. And to do this, we need first to address those barriers, behavioral factors that hinder people or our clients from accessing these services. And we can appreciate some of the few that we have mentioned, issues of not being able to go for seeking health care. Many of us here do not go to the health facility until you have something, pain in the head or pain in the stomach. That's when you go. But how do we develop this norm that going for a medical checkup is something that you can do? But also issues of stigma related to HIV, there are a lot, and this prevents a lot of people from going back to the services. There are GBV-related issues, intimate partner violence barriers, but also issues of knowledge. Do people actually know what it means to have TPT for a PLHIV? These are the issues that social behavior change needs to address. But also we have issue of social norms. How are we normalizing condom use among young people? How are we normalizing that a young female in Iringa can go to a facility and ask for a family planning service? So with this, as a program, we have integrated the SBCC component into our interventions. The interventions that Dr. Hema was speaking, they are all integrated with social and behavior change initiatives. There are healthcare workers who are, CHWs who are trained to ensure that they create demand during the outreach services. There are vaccination champions who are PLHIV, who are used to ensure that they are sensitizing and mobilizing fellow PLHIV to go for COVID-19 vaccination. They are doing the same for SECAP. They are doing the same for TPT. And to do so we have adapted the national campaign, the Triangle campaign, with all the materials that they were developed, and we are actually using these materials to make sure that we are reaching the people through various interventions, such as the IPC and small group sessions that are conducted in the community. We also use youth peers throughout our interventions to ensure that young people are engaged in their dialogue, but also they are center of implementing these programs, because having a peer-to-peer dialogue is key when we want to make sure that young people are going for HIV testing, young people are using condoms, but also young people are adhering to the services that they are supposed to be receiving. But also we are using the male champions. As you know, men are so busy. Anaamka saa 12, he's a boda driver. They don't have time to go to access these services. So we use male champions to reach these men into their existing areas. We call them hotspots. So if you are a boda, then this male champion will reach these men in areas that they are. And this, but also we don't only end up reaching them, but we are linking them to services and offering extended working hours for our healthcare workers in the facilities. So men can go anytime at a facility after they have been sensitized with our SBCC interventions, and they go to a facility where they can meet a healthcare provider at any time of their convenience, and so that they can get these services. Another component that we have is the community radio program, and this is we say we use the community radios because we believe people listen to these radios. And there are some very interesting programs within these radio stations that people would like to listen to. And they are local radio stations, and sometimes they use local means to ensure that people can listen to their programs. So with this, we are client-centered. So our CHWs, our treatment experts, and many other target audiences of our program are actually part and parcel of these radio sessions. They are invited to the radio stations where they can discuss their issues. We deliver our radio programs with these program beneficiaries, because that way they can be able to discuss issues that relate to them. And as you can see on the picture, you see this is in one of our male engagement activity. And this is a man who happened to be at a Boda Boda Kijiwe. And they are using the tools that we have adapted through the Frayangu campaign to communicate, to discuss some of the issues that hinder men from accessing HIV services, but also linking them to these services. And another very interesting program that we have with these men is that we don't only end up sensitizing them. We are planning now to roll out the coupon, service invitation coupons. So after each session, this man or this target audience will be handled a coupon. And this coupon, they can take it with them to their facilities, and they can be given a priority to get the services that they want to have. So with our radio again, in terms of localizing our content, we work with the CHMTs and RHMTs to see which indicators we're not performing well in the specific regions. So each region will tailor their message through these trusted individuals within the regions, and they can develop these contents and they can be aired through these radio stations. But the message is relevant to the audience that they serve, and so we can get more clients actually going to access these services. On the interest of time, I won't play the radio clip that is attached here, but sorry, I think we'll send this presentation and you can access this. So some of our lessons is that we understand that integrating SBC into service delivery program increases service uptake among our target groups, because it's actually the client who are driving our SBCC intervention. But for PLHIV specifically, engaging them in some of our SBCC activities will help in improving retention into HIV services. But for change to happen, we need to keep the dialogue going between clients and the providers. And so if we stop the dialogue, then people won't be able to go back to the services that we are providing. Thank you so much.
So thank you, Wanakulia, for giving highlights on the SBCC interventions. And our next presenter will take us through OVC program. We understand that Kezazi Hodale have just started implementing programs in the southern zone. With this, we'd like to hear from him what are the plans for this next program, but also how this program now is going to put our client at the center of discussion, or at the center of health service delivery. You're welcome.
Thank you, Dr. Chawote, for giving me this an opportunity to first introduce the Kizazi Hodari Southern Zone that is being implemented by Deloitte. This is a new program. But two, try as much as possible to indicate how client-centered concept is featured within the implementation. So Kizazi Hodari Southern Zone is a 5-year cooperative agreement, and it started in March 2022, and it will go up to March 2027. It covers 21 councils in 21. It covers 21 councils in 5 regions of Iringa, Njombe, Songea, Lindi, and Mtwara. And at the community level, we'll engage a total of 9 CSOs, local CSOs, to implement the project. Kizazi Hodari goal is to improve the health, well-being, and protection of OVC and youth in high HIV burden areas. We have got 3 objectives. One is to increase use of OVC platforms for pediatric HIV case findings, linkage, and treatment, including viral suppression. And this includes case identification, improve case management for children and adolescents living with HIV AIDS. But the second objective is to increase access to HIV prevention, violence, and the response services for OVC and youth. Here, basically, we are planning to implement some of the evidence-based prevention interventions, such as dreams, coaching boys into men, but also try to improve reporting and the responses of violence against children and the GBV cases as well. The third objective is to improve the socio-economic capacity of at-risk adolescent girls and young women and the OVC caregivers. We want to improve the social and the economic capacity of at-risk adolescent girls and young women, try to engage them in some of the economic activities, but again, improve the saving income and assets among the OVC households. Our technical approach is a family focused and child-centered, using the ecological model, targeting 3 program areas. As I said, one is comprehensive. All those beneficiaries who will be HIV positive or are vulnerable to HIV will receive a comprehensive services. But again, as I said, prevention, this will be implemented in Mufindi district, and specifically we'll implement coaching boys into men. And the third program is the implementation of dreams, targeting adolescent girls and young women in Mufindi District Council and Iringa Municipal Council. The program will be implemented across the 4 domains of health, safety, schooling, and stability in all the 21 council. Our overall guiding principle for the implementation is to support the government of Tanzania and the community system and structures by engaging and equipping them throughout the programming so that we can build a strong leadership and the governance, as well as promote the sustainability. This will include to ensure that implementation adheres to the national developed guidelines and the tools. Our second guiding principle is gender integration and meaningful engagement. And here we are planning to implement some of the gender transformative approaches, such as community gender dialogue and the meaningful engagement of male partners. The third principle, guiding principle, is routine use of data for continuous quality improvement through using the data so that we can improve the performance, but ensuring we have quality improvement teams at different levels to ensure that they are functional, those quality improvement team, and they use data to plan for improvement. And the fourth one is integration with the other PEFA programs with a focus on clinical partners such as Afya Yangu, EPIC, and Achieve, so that we can synergy resources and avoid the duplications. My last slide is specifically related to the theme of this, this meeting, the comprehensive client-centered approach through the NISIMs targeting OVC and the household. Basically, the concept of client-centered approach in Kizazi Hodari Southern Zone is focusing more on the identification and the building on the beneficiaries' strength and the capacities so that they can be able to meet their needs. And the process is in the National Integrated Case Management System. The National Integrated System guideline has provided some guidelines. There are standards, there are principles, processes, and the procedures that indicates on how community case workers should interact with the beneficiaries in providing case management. So the entire process of National Integrated Case Management System puts our beneficiaries in the center of service delivery. In short, we might say, nothing is done for them without them. This means that all the services that are provided to the OVC and their families is decided by them using their own strength and the resources available within their context. The aim here is to strengthen the capacity of the caregivers and the community to take charge of their lives to be able to meet their own needs and their children. So the most important thing when we are talking of the comprehensive client-centered, we are talking of ensuring we have community case workers who are able to interact effectively with the OVC household by ensuring that we facilitate a good working environment for them to be able to interact effectively with the OVC household. Thank you.
Thank you very much for the nice highlights. For the interest of time, we have been a little bit strict, and we have to use not more than 5 minutes for the rest of the presenters, not because of the otherwise, but the interest of time. So I would like to welcome my last two presenters who will give us highlights on their roles as a national level, who are responsible for providing policies and a guideline in implementation, but also monitoring and evaluation of the interventions. But also they will show us how they are partnering or supporting the different actors, and specifically with this Afya Yangu program in attaining the intended goals. So welcome first Dr. Mleo for the presentation, and then we will finish with Dr. Maukola. You're welcome.
Thank you very much, moderator and the audience. My task is just to say a few things about how we are related to the theme, that is comprehensive client-centered approach through
doing our TB services in the country. My name is Dr. Mleo, as I was introduced earlier on, and the Deputy Program Manager for National TB and Leprosy, and I'm here for the Program Manager. Our program is one of the oldest programs, 1977. So, and we have been doing well as far as TB services are concerned in the country, and we are doing well with the targets of WHO or global targets. And our task mainly, our document, our national strategic plan document was developed based on the client-centered approach. And we had an opportunity to include this in our current strategic plan, which is from 2020 to 2025. And then our main task as the program, we have to do the planning together with our stakeholders. And during the plan, also, as I mentioned earlier on, we did also this national strategic plan, which is ongoing. And if you have done the plan, then you have to do the monitoring and the evaluation of the plan, of the strategic plan, which probably will do the mid-year review, mid-term review, probably next year. So our main task is, as the program, at the central level, at the central level or the headquarters, to develop developing policies and guidelines to manage the TB services and TB and leprosy. Our program is TB and services, and also it incorporates the Central TB Reference Laboratory, which is situated at the Mwimbili campus. So I mentioned that we have the plan, which is ongoing. Also, we have to also develop the National TB and Leprosy Manual, which is now 7th edition, and the other guidelines, specific guidelines for specific cases like TB, HIV, MDR, management, communities, and other guidelines. And we do this with collaboration with our Prime Minister's, President's Office, regional and our TAMISEMI as our implementers. The other task for us is, as NTLP, we also do the coordination. The coordination with, as I said earlier, we work together with PRH and the implementing partners and developing partners. So we conduct meetings like annual general meetings, which is about to be held next month. And also we do a partners meeting. This partners meeting, the last one was conducted in the last 2 months near Arusha. And we do also quarterly meetings at regional levels. All this coordination, or we also do the coordination so that we can run the TB services in the country together. Our other task is to do capacity building for the coordinators. We have the coordinators at the national level. We have the coordinators at the regional level, and we have the coordinators at the district level. At this level, there are TB and leprosy coordinators at this level, and at the national level, the regional level, we have regional TB and leprosy coordinators. And we do, the capacity building is that we impact them with new guidelines, new information, and as long as the TB at the regional, the regional level, at the national level, and also globally. There are a lot of changes going on with TB, like treating of MDR, resistance TB, which is pacing very high, and then every now and then we have changes of management and like that. So, also at the facility level, we have to impact them with training so that they can do better, they can manage their work accordingly. The other task for us is to solicit funds, resources, so that we can run smoothly, can smoothly run the TB services and leprosy services in the country. That we work together with our development partners, WHO, Global Fund, CDC, and also USAID has been very in front line of during in soliciting funds to manage the TB services, as well as to sustain them so that we don't run short of these TB services. And this includes the commodities, as well as the quality of services that we needed to run in the country. So during this, during the fund, the resources, resources, we have to apply for like the funds from Global Fund, and like the current one we are running now is now ending this year, and then next year, and we'll have to write another one asking for a cycle probably that will take us from 2023 to 2027. And then we also apply other funds from CDC, PEPFAR, and USAID as well. And after this, then we have to do also the monitoring and the evaluation of our program, and also looking at areas of research where are we doing well, and where are we not doing well. So research, we have a research agenda that we in our strategic plan, which has about 9 objectives. One of the objectives is to research, and then during research we can come up with the answers for where we can improve our programs, programmatic and other operational and other services. Now, in short, that's what we do, and we collaborate with our Afya Yangu in these about 8 regions in the south of Tanzania. Thank you.
Yes, Doctor. You're welcome, Dr. Maukola.
Thank you very much. Good afternoon, delegates.
Good afternoon.
I have a disadvantage of being the last speaker. Probably is an advantage. Sure. So, as introduced previously, my name is Dr. Wena Maukola. I'm working with the National AIDS Control Program, Minister of Health, Dodoma, as a lead in the Strategic Information Unit, which is one of the units within National AIDS Control Program. We have about 4 units in there. 5, sorry. I'm one of the panelists on behalf of Dr. Anna Tirevembera, who is our program manager, who couldn't come because of other assignments. So most of the things have been spoken by colleagues, especially Dr. Rehema and Dr. Mleo. But I would like to shed light on a few things which can cement what they've already said. One is on what is client-centered HIV service, and in this I'll quote how PEPFAR has once defined it as service delivery by meeting people where they are and providing what they need. So if you look at these definitions, you can, if you go through from HIV care, from HIV testing, HIV treatment, ART monitoring, you would realize there's a clear mark of what people need and where they need. For example, with the HIV treatment, we know what people need is, for example, people need potent drugs. And you will agree with me, the minister moved from, for example, for adults and adolescents, we have moved from TLE to TLD because we know DTG-based treatment are more potent, they can fight resistance, and they are friendly compared to TLE. So this is one of the ways to achieve client-centered, because we want to give them what they need. But still, within HIV care and treatment, we need to give people where they are. We need to go where they are. So with the HIV treatment, we do have facility-led community ART. So we can go to the communities and have ART right from their doorsteps. So this definition actually echoes very clearly what we are doing. Second, I would like to, coming from strategic information background, I would like to call for a need to have evidence. I've seen a lot of data, and I know most of program data are descriptive, but we also have chances to show that what we are doing is has an impact and carry out a rigorous analysis of our routine data. So if you look into most of our reports, they are descriptive, yes, we can see trends going up, but I can tell you, if you do advanced statistical analysis, you may find our interventions may not give the right outcome or impact we are expecting. But luckily for us, National AIDS Control Program, we have done a rigorous analysis this year for multi-month dispensing, and we have seen a very significant impact. As well as for same-day initiation, we also linked the relationship or the association and the impact between these interventions and outcomes like retention. So we also need to do that. Thirdly, I would like to commend the work done by Deloitte, Afya Yangu. You are doing great, and as spoken by Dr. Mleo, as a technical arms of the ministry, our main job is to give direct guidance through guidelines, standard operating procedure documents and the like. So, but the implementation is done by PRAJ in collaboration with you partners. So that's, you are doing a very good job, and I can commend the work done by Deloitte by citing one of the examples which has been presented here. We are struggling with PrEP, and especially on tracking people on PrEP. And I can see you have a tracking tool, Kobo tool. So I don't know how it works, I didn't read, but I think you are somewhere, but I can assure you the minister is going ahead, has gone ahead, and I can give you two things. Here's good news and what we have achieved from Strategic Information Unit. As I said, we are struggling with tracking patients, and if you want to have a meaningful continuum of care from S facility to communities, you need to track our clients, but everybody here would agree with me, we are failing on that. So as a ministry, we have started to pilot unique identification using biometric in 5 S facilities, and luckily Morogoro has 2 facilities, and it's now 2 weeks since we started. So we want to have everybody registered, and this will start with HIV, but it will go into every aspect of health services. So that's a very important step towards tracking every one of us in every service we are doing. But we also agree with me, we're doing a lot in the communities, as we have shown here, but how do we capture data from community level? We are distributing condoms, PrEP is being distributed there, and so many other services. How are we tracking these patients? So we have what is called Unified Community System, and this one will also use some unique identification aspect to track patients from all these communities. And luckily, we will use tablets right from community levels. And once the people like CCW who are working from the community will have tablets and enter data, whatever service they are rendering, they now have paper-based tools, but eventually they will have electronic-based data capturing tool, which is real-time. The moment they press the button, we get the information. So these are the technologies which will make very meaningful link between the health facilities and the communities, so that we have client-centered HIV services which can be monitored. So to this end, I'm coming to the end of my presentation, and I should declare my interest. I also worked with the Deloitte. So if you have gone to the other end, or I've finished, you know. So I worked as the regional program manager for Dodoma, Turajali 1. So I'm at home. Asante sana.
Thank you very much, Dr. Maukola, for ending up our the first part of the presentations and the discussion. I would like now to welcome the audience. If there are any questions or areas that need to be clarified by our presenters. So I'll take 3 questions first, because of the interest of time, and then they will be responded, and then we see what time we have, because we'll have not more than 15 minutes for the discussion. Yes, the backward, the farthest.
Thank you very much, the panelists, for the very nice and elaborative presentation. It was really hard to hear what is going on in the community, especially as far as USAID Afyayangu Southern works concerned. My name is Dr. Ansbet Kingira from the Ministry of Health. I'm working with the National NCD Control and Prevention Program. And I really, one of the area of interest is how can we merge, or how can we intervene or make interventions of NCDs in HIV programs. A lot of work has been done as far as HIV is concerned, but we are currently seeing people living with the HIV succumbed with non-communicable diseases, and it's one of the...
Sorry, Doctor, your question directly, so I think it is well understood.
Okay.
That
Okay.
You want to hear on how we can merge NCD intervention with HIV/AIDS intervention.
Sure,
Is
sure.
that correct?
It's correct.
Okay,
As
thank
far
you
as
very much.
comprehensive centered approach is concerned.
Okay, thank you.
Yes, thank you very much.
The second row.
Thank you very much for a very good presentation. My name is Mohammed Mfaume. I work for DOD. I have a question to Rem, and I like the point client-centered approach. I would like to know, how do we use client-centered approach for the PrEP current? Because we have challenges with the PrEP current. We lost the people, we do not retain them, but I wanted to know, how do you use them? Oh.
Thank you. The second row on the left side, my left side.
Okay, my name is Yohana Yona Nyanza, student come from the University of Dodoma. Of course, to me, I feel impressive because I've learned a lot from Dr. Maokola. Of course, it is very important to make sure that we are able to track this patient, especially by including the use of technology. So, my question for how long this system will, if this system has been already being made. So, for how long this system will be used so that we can track this data for different diseases, especially in our country.
Thank you, Dr. Makola. Did you understand the question? Okay, thank you. The fourth one from Dr. Selina.